Good evening, ladies and gentlemen. I apologise for being late, being caught in Melbourne traffic. Part of the reason that I was caught is that, in fact, I've just moved to the other side of the river, which is like the other side of the universe. But I was formerly here at the Florey and ran the molecular psychopharmacology program here before I got lured and seduced by the delights of the other side of the river, which I must say is not quite like Fitzroy or Carlton or Parkbridge, Clayton. What I will do over the next 45 minutes or so is to try and present to you the most recent sort of findings in understanding major depression. And what I want to do by finishing a little bit early is to provide you with an opportunity to ask questions, to raise issues, and I guess to try and get a better understanding of one of the most significant public health challenges of our time. Let's start by calling somebody Brenda. Let's say she's 33 years old. Brenda is someone who is, for all intents and purposes, a success story. She is a lawyer in a legal firm in the city. She is articulate, she's confident, she's intelligent, and she's ambitious. A couple of years ago, Brenda found herself a partner, and they were shortly married, and one of the key goals of their relationship was to have a child, and in due time, Brenda fell pregnant. They had a baby about 6 months ago, and apart from the fact that the pregnancy was perfectly fine, the delivery was not. There were a lot of challenges. It was complicated, it was protracted, it was difficult. She was left with a lot of pain after the delivery, but she was tough, and within a couple of days, she felt that she'd recovered. However, within about a week, her partner noticed some changes. He noted that she started to cry a lot. He noted that she wasn't as attentive to the child as she should be at times when it cried, but at other times she seemed over-solicitous and seemed to be fretting at its slightest problems. By the time that anybody else noted, and that was the maternal and child healthcare nurse, Brenda was a blubbering mess. She couldn't look after the baby, she cried, she avoided the child when she could at all times. Her partner had to stay home to look after the child. Within a very short time after that, Brenda began to express thoughts that, in fact, she and the baby would be better off dead, and that she, in fact, had brought into the world something that would ultimately be the representation of evil for her and be the demise of humanity as we know it. Now, let's call somebody else Ali. Ali is 29 years old. Ali is a Hazara Muslim from Afghanistan. Those of you who know your geopolitical knowledge of West Asia and Central Asia will know that the Hazaras of Afghanistan are a minority for whom the Taliban have a particular and peculiar hatred. Ali's family fled Afghanistan to go to Pakistan after Ali's father was murdered by the Taliban. In Pakistan, things were not much really better because the Pakistanis didn't really want them there. However, Ali and his brother were able to get themselves into a local college where they were both studying. When they were going to the college one day, the Taliban hijacked the bus, ordered all the Hazaras off, and beheaded them all, except for Ali, who was able to flee. When he got back to his home, his mother organised for him to come to Australia via a people smuggler, as you might predict, and he ended up in an immigration detention centre and then was released into the community about 18 months ago. Ali can't think of anything else except the beheading of his brother, the fact that his mother is now without any sons and has to care for her daughters, and he feels intense guilt. Ali can't sleep. When he does sleep, he gets woken up by horrific nightmares of what's happened. He sits at home all day wishing that he was dead. Now, let's think of Gerald. Gerald is 53 years old. He is a self-made plumber. Gerald has dedicated his life to his business, which is his plumbing business. He's married with 3 adult children. They've now all left home except for the youngest son, who's still at school, about to finish, about to go to university. Because Gerald has spent so much time working in his business, his wife has essentially raised the children and now feels that they have left home. She is ready for a different life. She told Gerald that. She said that she no longer loved him and that it was time for her to strike out and discover a life of her own. Gerald first presented to services having taken a major overdose of medication. After he recovered, he said, "I'm fine, there's nothing wrong with me. It was a stupid thing to do. It was in the context of a separation. That's sorted out now, everything is all right." Gerald went home. He came back about a week later, deeply intoxicated with alcohol and having cut his wrists. He survived that, and lo and behold, he said exactly the same thing. Again, Gerald went home. Gerald didn't come back to hospital the next time because he drove his car into a tree. Gerald is now dead. The final person I want to tell you about is, let's call her Molly. Molly is now 23. Molly grew up on the so-called wrong side of the tracks. Her stepfather, mother's partner would be a better way to describe it, came on the scene after Molly's biological father left them when Molly was about 2 years old. This man was not a nice person. He molested Molly when she was a young girl. Molly didn't do well after that. Mum didn't really acknowledge what had happened, but their relationship ended, thankfully for Molly, when Molly was about 11. Molly then acted out. She started to take drugs. She started to hang out with the wrong kids. She dropped out of school when she was about 14 or 15. She began to self-harm, in particular slashing her arms, taking overdoses, using drugs and alcohol. Molly presented to services for the first time really when she was about 17 or 18, when she simply needed help, but every time that she was offered help, she of course rejected it. Molly is now 23. She still self-harms. She still has no sense of her own worth or value. She spends all her time taking drugs and drinking alcohol to forget the pain of her experience. Now, I've told you these 4 cases because these 4 cases are real and because all these 4 cases have one thing in common, yet to actually think what that thing in common is really beyond the comprehension of how we would normally group things. All those 4 people have major depression, yet it is quite clear that every single clinical presentation that I've described to you is completely unique and distinct from each other. Yet the symptoms that they describe and the commonality of the pathology which they exhibit shares features from which we can derive some information. What I want you, if you take nothing else away from this talk, is to recognise the two key elements of what I've said. The first is that each individual's experience of this type of illness is absolutely unique and personal. And secondly, that the pathology and the understanding that we can derive from such a heterogeneous group of presentations is necessarily limited by the very fact of their differences. So even though I'm now going to talk to you about major depression as if it was a single disorder, we all know that it encompasses a heterogeneity which is not easily reducible. Okay, so what do we know about major depression? The first thing we know is that it's pretty major. It's the second leading cause of disease burden in the world globally. Now that was thought in 1996 when the World Health Organization first commissioned this survey that wouldn't occur until 2020. They got it wrong by about 10 years. In 2010, it became the second leading cause of global burden of disease, second only after ischemic heart disease. So ahead of cancers, ahead of stroke, ahead of other psychiatric and other medical disorders. The prevalence of major depression is going to be somewhere, so this is lifetime prevalence, somewhere in the order of about 1 in 6 people. 1 in 5 is a nice number to remember because it's 20%, but the reality is it's probably a little bit less than that. It's probably more like 1 in 6. So if there's 150 people in this room, 25 of you will have major depression at some point in your life. It respects no cultural, social, ethnic, political order whatsoever. Every single group of people that we know experience major depression, and in fact, one of the most interesting things about it is that evolutionarily, major depression exists in other species. We can't say that about schizophrenia. We can't necessarily say that about anxiety disorders. We can't necessarily say that even about dementias, but we can say that about major depression. Last year, I had the fortune to travel in Borneo, and in Borneo, I was able to see the orangutans in their in these camps that had been established to look after orphaned infants when their mothers in particular had been killed as a consequence of the palm oil plantations and deforestation. And being who I am, what was the thing that was patently clear was that there were depressed orangutan cubs, or not cubs, they're, well, let's call them cubs for the sake of this argument. They were clearly depressed. They had been separated from their mum. Some of them had obviously got over it and were functioning what might be termed reasonably well, but there were others that looked for all the world depressed. Closer to home, our dog had a knee operation about 2 years ago and couldn't walk, and in fact had to stay in a splint for an extended period of time. Depressed, no question about it. Went off his food, wouldn't acknowledge us, refused to socially interact or engage with us. About 6 weeks later, when he was able to walk and move, back to normal. I don't have any real question that many types of mammalian species experience what can only be described as a depressive syndrome. And I think that's very important for us to recognise when we try and understand the neurobiology. Within any 12-month period, about 1 in 16 people will get depressed. So I've told you that 1 in 6 people will get depressed over the course of their lifetime. Within a 12-month period, approximately 6% will get depressed. And The thing that's interesting about the prevalence of depression is that it's twice as common in women as it is in men. Now that's really interesting because you can think about, well, where's this data from? This data has come from a wide range of representative countries, so both high-income Western European type countries such as Australia, and in fact New Zealand has been a source of information in this, as well as the US and Canada, but also middle-income countries and also low-income countries. One of the things that's really interesting was I looked to see whether or not anybody had examined whether this difference in prevalence of major depression between the sexes occurred in matrilineal societies, and guess what the answer was? The answer is yes. It still persists in matrilineal societies. So it's not necessarily a direct function of patriarchal organisational systems. Now, Jane's told me I don't have a pointer, so let me see if I can use this mouse instead. No, I can't. What I want you to do is look at the chart on the right-hand side. The chart on the right-hand side divides up the incidence, the prevalence of depression according to males in the blue and females in the orange, and according to the age groups along the y-axis. There are a couple of things that I want to make about this slide. The first is that, and you probably can't see it from where you're sitting, but even in that age group of 1 to 4, there is a prevalence of depression, and that there's a prevalence of depression right through the entire age spectrum. The next point I want to make is that major depression affects young people, and that was highlighted principally by the stories that I related to you, but also from the actual data, which suggests that the peak age of onset of major depression for women is between the ages of 20 to 24, and for men it's slightly later, it's between usually 25 to 29. But that's a pretty broad spread, so that any time really from the ages of puberty and adolescence right through to people in their late 50s, early 60s, depression will occur as a new disease and a new disorder. You can also see the very significant excess with regards to women compared to men. Okay. Just get this worked out. Yeah. So what is major depression? I've given you clinical examples of what major depression is, and it's pretty straightforward. I'm sure that most of you will have some experience of what major depression is, and unfortunately many of you will think you know what major depression is because you've had some personal experience of something which feels like it should be called depression. What I want to emphasize is that major depression is a disorder, it's an illness, it's not unlike having a heart attack or not unlike having a diagnosis of a significant cancer or a stroke. It is not something which, if you've not had it, you think that you may have some experience or knowledge of. It is not the experience of normal sadness, and it's not even the experience of significant grief or loss. There is no question that some of the associated feelings and symptoms that you might experience if you've had those experiences will be similar at some order of magnitude to what it's like to have major depression, but major depression is altogether a different constellation. And any of you who've had major depression or have had loved ones who've had major depression will know exactly what I'm talking about. The problem is that we have no way of quantifying this. We don't have any x-rays, we don't have any blood tests, we don't have any other investigations that we can do that can objectively demonstrate to the rest of the world when someone has major depression. What we unfortunately are left with are a series of clinical features symptoms and signs which can be interpreted and diagnosed by health professionals to arrive at the diagnosis. Now, this is what medicine was like 120 years ago. You know, this was what endocrinologists had to essentially do to diagnose something like Alzheimer's disease or to diagnose something like a lung cancer. You listen to the chest, the person complained of symptoms such as coughing up blood or something like that, and you then executed your clinical skills to arrive at a diagnosis of lung cancer or a diagnosis of a brain tumour or a diagnosis of ischemic heart disease. The rest of medicine has moved on in the last 100 years, but unfortunately psychiatry is still searching for the clues that will allow us to objectively define disorders such as major depression or schizophrenia. So, to overcome some of these challenges, what we've tried to do is to develop a system or organisation of the key clinical features of psychiatric disorders so that when I talk about somebody having major depression, that's the same as if somebody in Canada or New Zealand or the United States or Germany diagnosed major depression. And there are two major classification systems. There's the first, which is the International Classification of Diseases, which is the World Health Organization, and they've come up with a series of essentially criteria. And then there's the American Psychiatric Association, the ICD, WHO ICD one is for all diseases. The American Psychiatric Association came up with one specifically for psychiatric disorders, and this is known as the DSM, which I'm sure many of you would have heard of. It's the Diagnostic and Statistical Manual for Mental Disorders. It's just come out with its 5th edition. It's the one that for the most part is used clinically in Australia by most psychiatrists and psychologists. It's not to say that the ICD-10 in its current version and ICD-11, which will come out next year, are not used. They are used as well, but this is the one that is probably in greatest common usage in Australia. The DSM-5 definition of major depression is what's up on there. The first thing is that the person needs to have experienced the following symptoms for 2 weeks. It's 2 continuous weeks, and it's 2 weeks where most of the time, for most of each day, they're experiencing these symptoms. It's not that you wake up in the morning for 15 minutes and feel a bit glum because you've just lost the preliminary final. It is that for most of the day you experience these symptoms. Now, the 2 key symptoms are the ones that are up there: the persistent depressed mood or the loss of interest or pleasure in things which people usually enjoy. And it doesn't matter what it is. It can be simple things like gardening, reading, watching television. It can be more complex things like engaging in work or social activities, or it can be things like you no longer enjoy the presence of your child or children, in the case of Brenda. Not that acute or that severe, but the indication being that things that you normally would enjoy, you no longer do. The persistent depressed mood is important to qualify because children and adolescents and men don't complain of a persistent depressed mood. They complain or exhibit irritability, anger, short temper instead. Not all men, but many men. You have to have one of those 2 symptoms, and then you can either have 3 or 4 of these ones for a total of 5 symptoms. And the 5 symptoms, the other symptoms are listed up there. Feelings of guilt or worthlessness, and I've given you examples already of what that's like. Sleep changes, and this is obviously either increased sleep or decreased sleep. Mostly people will complain of insomnia, waking up in the middle of the night with horrific thoughts of how awful they feel and about how overwhelmed the day in front of them is going to be, even though there's nothing special happening in it. People talk about concentration and memory problems, and people who are significantly depressed don't remember anything. and they feel as though they don't remember anything, but if you push them and press them, they usually do actually remember. But it's the subjective sense of the loss of memory, and the subjective sense of the loss of memory is entirely attributable to the poor concentration. So it's the fact that they can't concentrate, which means that they can't learn the information. It is not dementia in the way of Alzheimer's disease, where in fact they don't remember. Important. Fatigue, loss of energy is invariable. People can sometimes either move or think too slowly or much faster than normal. That's called psychomotor agitation or psychomotor retardation. It's now generally uncommon, except for the psychomotor retardation. People feel as though they're slowed down in their thinking. Now, appetite and weight changes. People go off their food commonly, but very occasionally people have the opposite, and they will eat, and they will eat in a way to attempt to console themselves. And so they will eat more and put weight on, but much more common is a loss of interest in food. The suicidal ideas and plans, actions, which I've illustrated already. Obviously, these symptoms impair people, and it's only when they begin to impair people and cause significant problems in their day-to-day functioning, either at a personal level or in their interaction with their environment, their family, that it comes to the attention of health services and health professionals. Now, these are the core symptoms that DSM-5 used to define schizophrenia, to define major depression, and it's similar to what ICD-10 and ICD-11 will use as well. However, in addition to that, people with major depression have a whole host of other symptoms. And I've put those symptoms up there because these may be the symptoms that other people notice in people who are depressed, even though the depressed person may not admit to them, and they include things such as anxiety and feeling intensely fearful, crying more than usual. People will notice that they cry at the drop of a hat. They watch something bland on television. They in fact watch an advertisement that's got a bit of a sad moment and they burst into tears. People can burst into tears spontaneously. Irritability, crankiness, anger. I've talked about that in relationship to adolescents and others. Physical complaints such as aches and pains, using alcohol and drugs and cigarettes. People lose interest in sex. People have changes in their mood during the day, so that in fact the common one is that people wake up feeling terrible, but by the end of the day they actually feel a little bit better. Sometimes it can be the reverse. And then bodily function changes. So people notice things like they become constipated. Women will notice changes in their menstrual cycle. And these are changes which are directly attributable to the depressive disorder. Now, having said that this is what the definition of major depression is, we come to the big question. We come to the big question which says, well, you've described for us a whole set of clinical features that everybody's noted. You've described for us some of the criteria that are used to define what major depression is. What is it that causes something like this? What is it that causes a disorder that can have such profound and devastating effects upon individuals and their families? With something like ischemic heart disease, it's straightforward. You know, it's a blockage or a narrowing of the coronary artery. Somebody with a cancer, you've got a lesion which might be in some part of the body, which is going to cause symptoms which then present to services. But what about major depression? The bottom line is that we've got no idea about what causes major depression, and that's probably taking too complex a perspective on the issue. What we can say is that there have been a whole series of factors which have been identified or associated with the illness. And I've listed some of these up here, and I've listed them in a way which is meant to indicate one thing and one thing only to you. The first, or more than one thing, but a couple of key things. The first thing is that major depression is a disorder of the brain. If you don't have the brain, you're not going to get major depression, right? Now, The issue with the brain is that when we think of the brain, we think of it in way too simplistic form. We isolate it as if it is something that sits within our skull and which somehow dictates what the rest of the body does. That's absolutely not the case. The brain is an organ in the body in the same way as your heart or your liver or your stomach or your kidneys or any other organ you like to name. In other words, things that happen in your body affect your brain. And they affect your brain in such a way that your brain then responds in the same way that if there was a blockage in your stomach would respond appropriately. The second thing is that the structure and function of your brain is determined by a whole host of factors, of which I've only listed some of them, such as your genes, such as your family history, and such as your physical health. All of those things contribute to the way that your brain develops in the first instance, that is, how it's developing in utero and then in the immediate postnatal and subsequent periods. But your brain doesn't stop developing once you become an adult. Your brain is a plastic organ which is constantly changing and adapting to the environment in which it is exposed. That has very significant implications, obviously, for how your brain can change and adapt to changes in your environment, and more importantly, your brain then allows you as an organism to adapt and respond to the environment around you. What this diagram is meant to indicate is that all of these factors have very significant contributions upon your mental health, and that your brain is simply the transducing station for all of those environmental factors. And those environmental factors include things such as the genes which are responsible for the brain's construction and the brain's ongoing function. I'm going to come back to that because it's fundamentally important for us in understanding how major depression occurs, for us to be able to get this complex and nuanced interpretation of how the brain works. I want to in particular talk about three major sets of causes, and I've divided them up there into genetic, molecular and neuroimaging. Okay? I am unashamedly, even though I'm a psychiatrist, I'm unashamedly a neuroscientist, and I'm going to focus upon the neurobiology of major depression because I think this is where the key advances in our understanding of the disorder are going to come about, although I'm going to talk a little bit about other factors subsequently. So let's first look at the genetics of major depression. There is no question that if you have a family history of major depression, you are more likely to develop the disorder. And it increases the rate, the heritability of major depression, to about 37%. That's a pooled estimate from a whole series of studies which have gone estimated between 17 to 75%. So 37% is the take-home figure from the most recent meta-analysis. 37% is very high, but it ain't nothing compared to autism or schizophrenia or bipolar disorder, which are 70 to 80% heritable. Okay? So what that's saying to us is that yes, there are significant familial heritable factors, but there's a lot of other things that are happening which mitigate that risk. The greatest heritability is around those factors that I've listed up there, which are people who have recurrent major depression. So if you've got a family history of recurrence, then you're more likely to have recurrent major depression. The severity of the illness. So in particular, if you happen to develop the sort of psychotic depression that Brenda had, the young mum, That's the sort of heritability that we see in families. Treatment response. Now, this is critically important. So if there's anybody out there who has a family history of major depression and they happen to develop major depression themselves, the first question you should ask is, was there any treatment that got your family member better? Because if there was, that's the treatment you should take first up. Okay? Treatment response is highly heritable, and it's a very good predictor of subsequent response in other family members. And the reverse applies. If your family member took something that didn't work, there's not a lot of point you trying it. And then the last and saddest heritable factor is suicidality. So suicide runs in families, and it runs in families almost independently of the mental disorder which causes the suicide to occur in the first place. Okay, now, when we've looked at genetic studies, so knowing that there's this high rate of heritability, what is it that we can identify from genetic studies? The first thing is that we went searching for genes that we thought might potentially be involved in major depression and what we thought were features associated with major depression. So the first thing, of course, was stress. Everybody understands that stress is associated with major depression, so let's look at stress-related genes. And there are some stress-related genes that do come up, and they keep coming up in these studies, and they're clearly genes which are potentially of interest. However, the sad fact is that they contribute very little to the general development of major depression, but they do provide us with some insight. So I've listed genes up there. It's not important that you know what those genes are. They're the ones associated with the cortisol system, because cortisol is the major stress hormone. The reason I put them up there is because they potentially provide us with molecules which we can then target new treatments for. The bad news is that one of the first ones that we developed a drug for, which was CRHR1, the drug was tried, the drug's been tried extensively, it didn't work. That's not to say that we shouldn't try this approach, it was just unfortunate that the first cab off the rank failed. The second group of genes that were looked at extensively refer to the monoamine system. The monoamine system, and I'm not going to talk a lot about this because this is the site of action for the antidepressant drugs. So this is serotonin, which many of you would have heard about, and which affects a lot of the body systems that are affected by depression. The monoamine system has been implicated in the pathology of major depression because we think this is where antidepressants work. So if you like, antidepressants were discovered completely accidentally. It was purely a serendipitous finding. Okay, so everybody understands that there was no great, clever, magical science about developing antidepressants. They were identified as a drug there was a drug which caused depression, and so the drug that was the opposite of that was tried and given to people who were depressed, and lo and behold, it worked. So we then tried to discover how it worked, and we discovered it worked through the serotonin system. Hence, the serotonin system is the major system that's been implicated in depression. We've looked at a whole range of genes, and some of them keep coming up. I want you to look at the first one, which is the 5-HTTLPR. That's just the serotonin transporter. You don't need to know anything more about that, but I will present it to you in a moment with regards to its implication in depression. These are the systems which have been targeted by the major drugs that are effective in the treatment of depression, and that's why they're up there. However, because they don't explain most cases of depression, what's happened is we've taken a different approach. What we've said is, let's get all the patients that we can with depression, let's get healthy controls who've never had depression or don't have a family history of depression, and let's see whether we can find genes using some of the clever new genomic technologies that are available. So these are called genome-wide association studies, where we look across the entire genome to see whether or not there are differences in people with depression and compare them to people who've never had depression and don't have a family history of depression. Now, initially these studies started off with 100 patients and 100 controls, and now they're up to these sort of numbers. So the last study that was done had in excess of 100,000 cases and controls, about 30,000 cases, 70,000 controls. These studies are, well, gigantic to say the least. They cost a fortune to do. They're done across the world, so different research groups in different countries collect the data, collect the samples from patients and controls, do the analyses, and then all the data gets sent together and gets analysed as one large group. The largest one that's just been done, just been published, found nothing. Found nothing. Okay? Now, that is extraordinarily disappointing because you would have thought that there should be a signal. What it's probably suggesting, and what the authors argue, and I think it's probably an accurate argument, is to say that it's not to say that there aren't genetic factors responsible, but that each genetic factor is contributing a tiny proportion of the overall genetic risk, and you need to have a whole lot of these genetic risk factors in one individual before it transmits itself as a genetic risk factor for depression. Another group took a different approach, which was quite a clever approach. What they did was, they said that maybe the reason that these big studies have failed is because they've used a multinational approach. So what they did was they went, they were a Chinese group, or in collaboration with a large number of Chinese groups. They got very specific patients. They got females, all of a single ethnic group within China, but from a number of different hospitals. And they got female controls who had no history of depression and no history of, or family history of depression. And they did a smaller study, only 8,500 cases, 8,500 controls, and they did come up with 2 genes, and then they replicated that, and one of those genes, one gene came up. So this type of approach does hold further promise, and we may well identify new targets. However, it would be fair to say that at this point in time, even with that sort of target being identified, that's only going to explain a very small proportion of the total genetic risk for major depression. The other point that I would make, of course, is that we then don't know, of course, whether this is going to translate into other ethnic groups, and they would need to be tested as such. The last point I want to make about genetic factors is around treatment response. So not only have we looked at with regards to the cause of major depression, we've also looked with reference to whether or not we can predict treatment response. And there have been a number of genes that have come up as though they are associated with treatment response. Again, the serotonin transporter, which is the first gene there. However, it would be fair to say that at this point in time, these findings are not robust enough to translate into a clinical test that we can give to a patient and to say, okay, well, because you've got this particular genetic variation, we should give you this particular drug. But that's clearly the direction that we'd like to head in something like that. Now, I've told you that genetic factors are not sufficient in themselves. What are the environmental risk factors? Well, these are the well-known environmental risk factors, and they are absolutely predictable, and I'm sure that if I'd asked you all before I put the slide up, most of you would have come up with most of them. They are the things that you might predict. The first one may not be, but in fact, antenatal factors such as maternal stress or infection or substance use during pregnancy increases the risk. Perinatal factors such as low birth weight and birth complications increase the risk, not of the mother as in the case of Brenda, but in fact in the infant, not as an infant, but as an adult. Okay? Clearly, deprivation of postnatal, of normal parental care during infancy is very important. So children who aren't given appropriate parental care by a significant other as in the case of the orangutans of Borneo, the same story applies to the humans of Melbourne. Childhood factors, clearly, physical maltreatment, sexual maltreatment, neglect, early parental loss, so in particular parental death, and for women it's losing a mother before the age of 11. Family conflict and violence, clearly obvious factors. And then across the lifespan, things which are stressful life events which are catastrophic in meaning to the person. Okay? So again, the case of Ali having lost his father, having lost his brother, and then having lost his mother, in the sense that he has ended up in Australia whilst his mother is still staying in Pakistan. Substance abuse, toxic exposures, head injury, they're all important contributing factors. However, the risk, if you have one of these, of developing major depression is in the order of increasing your risk between about 1.2-fold times to about 5 or 6-fold times. The important thing to remember is that none of these things in isolation is going to guarantee that you get major depression, and if none of these things happen to you, you're still quite vulnerable to developing the disorder. Okay? So none of these things are either cause or effect. The way that we can interpret this, on the one hand, these environmental factors, and on the other hand, these genetic factors, is one of the most amazing studies that occurred at the beginning of this century, which is this study by a group that looked at children in New Zealand, in Dunedin. It's the Dunedin cohort study, and it had the opportunity to follow up children from the time that they were born, and now they're in their mid-30s. This study was done when the kids were aged 26, and what it looked at was depression. So it looked to see, and this is about 1,000 children, just over 1,000 children, 1,032 children. It looked at depression at the age of 26. And what it found was that you could then classify the children according to whether or not they experienced abuse, and the abuse was defined broadly. So you can see there, 3 groups: no abuse, moderate abuse, severe abuse. What you can see there in the dotted line at the bottom is, so the x-axis then talks about your risk for the y-axis talks about your risk for developing major depression. The dotted line across the bottom says that there were a group of people that, irrespective of whether they experienced no abuse, moderate abuse, or severe abuse, had essentially the same risk for developing depression. That abuse was completely irrelevant to their later likelihood of developing a depression. So this is abuse between the ages of 0 to 10, depression at the age of 26, or having had a previous episode of depression. However, the next group in the squares, the group who had moderate or severe abuse had higher likelihoods of developing depression compared to the group who didn't have any abuse. And then the very top line in the circles, there the risk of developing depression was even greater if you'd had severe abuse compared to moderate abuse compared to no abuse. Now, what differentiated those 3 groups was the genetic character of that serotonin transporter. So that people who had one particular form of that gene, the bottom line there, were in a sense protected from the effect of severe abuse for them to develop major depression. Whereas if you had one other particular form of that gene, your likelihood of developing major depression more than doubled if you experienced severe abuse compared to those who had the same gene but had no abuse as a child. So this is the first study, and subsequent to that there have been a number of other studies that have extended this, but this is the first study to demonstrate that we can't think of genes and environment as independent elements which somehow just come together in an individual and carry separate risk. We have to think about genes and the environment as interacting with each other, and interacting with each other in a beneficial way, but also interacting with each other in a pathogenic way to increase the likelihood of major depression. But this also applies to other psychiatric disorders and likely applies to most other physical disorders that we experience or know about. How is this possible? How is it possible that whether or not you get abused as a child can interact with your genes such that you then are more likely or less likely to develop depression as an adult? And the way it occurs is through a mechanism called epigenetics. Now, I'm not going to tell you a lot about epigenetics, but epigenetics is the mechanism by which environmental influences, by interacting with cells and cells in your brain, will alter the way that your genes express themselves and the way in which your genes regulate themselves. Epigenetics occurs all the time, and it occurs in both reversible and irreversible ways, and it is the mechanism by which things can be altered in the way you function and behave and your organs function and behave in response to your environment by directly interacting with your genes. It is not specific or selective for major depression. It occurs in every single interaction of our living bodies, and it is, if you like, the big sort of hot topic in biology at the moment in terms of how this occurs on a day-to-day basis in adults, children, infants, in development, and in particular, the role it plays in augmenting and influencing brain development. Okay, so we're going to leave genes there. The next bit that I want to talk about are the molecular elements that we know about major depression. Now, this is a lot less challenging because this is simply looking to see whether or not we can identify in people markers that can be used to diagnose the disease in the same way that we might have a blood test to diagnose diabetes, to look in the brain to see whether or not there are things which we can identify in the brain which can give us a clue as to what it is that's changing in the brain so that we can develop new drugs, and to see whether or not there are ways which we can develop tests to determine whether or not a person is going to respond to a treatment or not respond to a treatment. These types of markers are called biomarkers. The major ones that we've looked at in the blood are things that we think might be related to the pathology of the disorder, and so I've listed some of them up there. I've grouped them into three groups there. So the biomarkers such as the BDNF, VEGF and IGF-1 are growth factors. So these are things which alter brain function and regulate brain function and development. The next group are called the pro-inflammatory cytokines. And the thing that's interesting about them is that they are the molecules that your body secretes or produces in response to stress and inflammation. So these are things that your body uses to counteract an infection that you might have, or that if you happen to be particularly stressed by something such as starvation or sleep deprivation, your body produces these pro-inflammatory cytokines. Now, what they're doing in the brain we don't really understand because they have a dual role in the brain. They fight off infections if you happen to have an infection in the brain, but they also have a signalling role in the brain where they allow communication between neurons or brain cells. So what they're doing and why they're dysregulated in major depression, we don't really understand, but we think that we can potentially target these systems and thereby improve or treat depression. And then the last one, the HPA axis markers, are the ones that are directly attributable to your stress axis. So these are things like cortisol and other stress-related hormones. Now, the last thing that I put up there is an approach that a number of groups have used, which is to say, well, you know, we really don't know anything about major depression. What we'll do instead is we'll take blood samples from a large number of people, say, you know, 500 people. We'll then look for a whole range of proteins in their blood, in the order of 200 different proteins, not really knowing that these 200 proteins are not really related to each other. We don't really know much about them, but we'll just measure them. And then what we'll do is we'll see whether we can use statistical methods to separate out one group from the other group. And that's what that approach has done. I must say I'm a bit sceptical about what that's likely to lead, but there have been a number of papers which suggest that there might be some diagnostic tests using that type of approach. Let's wait and see. I'm not going to hold my breath. Now, the final section that I want to talk about briefly is neuroimaging, and this is about looking inside the brain and using the high resolution imaging technology such as magnetic resonance imaging and other such, or MRI as you might know it, and other imaging modalities to see whether or not we can understand what's happening in the brain. What we've understood is that there are a number of key systems that are involved in the way that that are affected in major depression, which affect the way that people feel. The first is in emotion and reward processing and regulation. The second is in the way that we interpret that information. And so in a sense, it's how we respond to emotional stimuli and the way that we regulate that emotional stimuli. So the best example of that would be, for example, you're with a group of people and you happen to win Tats Lotto and all your friends haven't won Tats Lotto and they're all looking dejectedly at their numbers. Now your response might initially be to jump up and down and to scream, but you might also look at your friends' sad faces and just modulate the level of excitement that you feel. Okay, so that's what I'm talking about there. And then the last one is about the effortful regulation of emotion. So this is about making sure that you discharge the appropriate amount of emotion in the appropriate context and place. These are the brain regions that have, generally speaking, been associated. So it's really the front part of your brain, plus a bit of the brain which controls emotion, which is called the amygdala. And the amygdala is a very ancient part of your brain, which is found in many other species. And similarly, the ventral striatum, which regulates the amount of reward that you experience. Now, people have looked at these structures, and the biggest study to date, looked at about 7,200 healthy people and about 1,700 people with major depression, and it looked using a whole set of brain scans, MRI brain scans. And what it found was something that was quite interesting, which is, if you see 0 in the middle there, everything on the left-hand side shows a reduction in the amount of brain tissue. Everything on the right-hand side shows an increase. The only thing that's increased is your lateral ventricles in people who've got depressed. The problem with your lateral ventricles is it's not a structure, it's a space. So the fact that you've got an increased space simply means that your brain has shrunk in other ways and the space has got bigger. The only thing though, if you look to the left of the slide, the only thing that's actually statistically significantly smaller in people who are depressed is a structure called your hippocampus. Your hippocampus is the brain structure which is critical and central to memory and about memory function and about being able to process and interpret and respond to memory. And it's all types of memory. However, it would be fair to say that there are quite a number of other structures there which look like they're smaller in depression, but that don't reach statistical significance in this particular study, which, as I said, is the largest study to date. What was also interesting, though, was when they looked at people who either had their first episode of major depression, which is in blue, so this is the right hand, your left hand on that side, the blue who had their first episode of depression or the hatched bars, which are people with recurrent episodes of depression, so multiple periods of depression. And again, it's the hippocampus which comes up as being reduced, and it's reduced in people who've had recurrent episodes. So in a sense, having more than one episode of depression seems to result in a smaller hippocampus. And whether this is a general feature or whether the hippocampus is more sensitive to these pathological processes, we don't know. The other thing that's interesting is, if we look on the right-hand side, what we can see is a differentiation between people who've had their first episode of depression before the age of 21 or after the age of 21. Before 21 is in blue, after 21 is the hatched bars, and you can see that there are two structures there where, in fact, people who've had first episode early onset depression have greater volume loss in the hippocampus and the amygdala, which suggests that if you're going to get depressed, try and leave it to as late as possible. Now, this is something that I completely don't understand. This is the new field of taking that data that I've just showed you and combining it with functional studies to look to see where the brain is got the most amount of blood flow and the most amount of activity, and then integrating those two images mathematically. And it is, would be fair to say, going to revolutionise the way that we think about psychiatric disorder. It's a field called connectomics, and what it's doing, and now I really do wish I had a pointer. Oh, does that work? Yeah, okay. So on the top here, you've got straight MRI scans, brain scans, and this just shows you structures in the brain, essentially just cutting through the top of your head like that, like the lift top head in the advertisement. Okay. This image here is showing you the white matter tracks, and the white matter tracks are the bits of the brain which connect the different parts of your brain together. Okay. So if you like, this is showing you the actual bits of your brain, the grey matter where all the activity is occurring, and then the white matter, which are like the highways or the paths which connect the information flow between the various parts of the brain. The next line of images is showing you, when you look at these blood flow images of the brain, which parts of the brain seem to light up together, and that's showing you using three different statistical approaches to that problem. The next set of images is then showing you electrical activity in the brain and showing you which bits of the electrical activity of the brain are coincident in time. Okay? And then it's translating that image or that functional data into images which relate. So this is the white matter again, so this is like this particular image, but looking at it from an electrical perspective overlaid a structural perspective. And then this is computing that statistically. What that results in are these pictures. And what these pictures are showing you is, these are the systems that I talked about just 2 slides ago, as being the bits that are involved in emotional and reward processing. This is now showing you the difference between healthy people's brains and depressed people's brains in terms of their connections. The red indicates that there's a decreased level of activity in those particular brain regions. The blue is indicating that there's, no, sorry, it's the other way around. Blue is indicating reduced levels of activity, connection between brain regions. The red is indicating increased levels of connection between brain regions. So this is really getting to the story which is saying that the changes we see in major depression are not just related to a reduction in the volume of the brain tissue, it's actually changes in the way that different parts of the brain are signalling to each other. And this is getting to where those changes are occurring. The reason for that, of course, is that once we do that, we can start to look using a range of other approaches into those brain regions to find out what the differences are. Okay, so now that we've talked about some of the causes of depression, or certainly what we think might be contributing. Let's very quickly, and I realise we're out of time, but I'll very quickly go across some of the current new thinking in terms of treatment. I don't need to labour this. 2,500 suicides in 2013, that's more than road traffic accidents, drug-related, HIV-related, and homicide deaths in Australia combined. 60% of suicides will have major depression. Approximately 1 in 6 people who have major depression will suicide. And in addition to those deaths, there's a significant interaction with ischemic heart disease, which I don't have time to talk about, but which is very important, so that if you do have a heart attack, make sure that if you get depressed after that, you tell somebody and you get treated. Otherwise, your risk of dying is increased about 4-fold. Okay, treatment. This is what we know. This is what works. And I've got it according to whether or not you've got mild depression, moderate depression, or severe depression. The stars indicate the relative efficacy of treatments. Okay? So if you've got mild depression, mild to moderate depression, psychological therapies, if they're for you, are fantastic. If they're not for you, antidepressants will work. If you've got moderate depression, then the best thing is a combination of psychological therapies and antidepressant medication. And if you've got severe depression, then you're probably going to need to have antidepressant medication. And if you're very severe, such as in the first case, or the first 2 cases I talked about, then you might well need to be hospitalised and you might well need to receive electroconvulsive therapy, otherwise known as shock therapy, which is the most effective treatment for severe depression that we have. Efficacy rate of about 90% or so. Okay, I'm not going to say anything more about these treatments, except that standard antidepressant treatment, doesn't matter which drug you choose, pick any one you like, they work in about 60 to 65% of cases. Okay? We don't have any test to tell you whether the one you try is going to work or not work. It's entirely a question of trial and error. If you've got a family member that's responded, that's the one for you to try first, but apart from that, we don't know. That's why doctors get it wrong all the time. Well, they get it wrong in 1/3 of cases, okay? And you've got to keep trying antidepressants before you find the one that works for you best. Now, there are 3 things I want to talk about very quickly, which are really the next generation of treatments. The first is a drug called ketamine, which is used as an illicit drug by various members of the community. It's also used as an anaesthetic, in particular for children. In sub-anaesthetic doses given intravenously, it appears to have a very rapid onset of antidepressant action in people who have not responded otherwise to antidepressants. Standard antidepressant treatment usually takes between 2 to 4 weeks. Ketamine can work not quite at the end of the needle, but when the person then comes out of treatment, in the next couple of hours or so, will notice a response. Problem is, it may not be sustained. You need to have it repeatedly, so it's not just a single intravenous injection. You need to have it maybe weekly or so. And the other thing is, we don't know how long the effect lasts. So for some people, it's only for a few hours. For other people, it can be longer than that. It's currently in trials, and people are trying to now design drugs which work in the same way as ketamine, but which can be administered orally. So just wait in that space, and you might well see a new set of antidepressant agents mimicking the effect of ketamine. There are 2 other treatments that I want to mention briefly, and they are not tablets or medications, they are physical treatments. The first is transcranial magnetic stimulation, or TMS, and this involves applying a magnetic field outside the brain. So you hold a magnetic emitting electrode away from the skull, but it essentially is transmitting magnetic pulses into the brain. It is approved for treatment, and there are a number of services in Australia or in Melbourne that provide TMS. It would be fair to say that the results have been mixed. There are people who've in particular got treatment-resistant depression who respond beautifully to it. And if you do have treatment-resistant depression for which nothing else has worked, I would recommend that you consider a trial of something like TMS. The problem is that we haven't worked out the parameters around which it works best. So how frequently it gets administered, what type of administration is most effective, and what type of dose you should get. However, there are a couple of places, and in particular the Alfred Hospital is probably the site of TMS for depression, certainly in Melbourne. The last thing that I want to talk about, and it's very exciting, is this thing called deep brain stimulation. Now this has very bad sort of concept because people think of it in the same way that they might have thought of a lobotomy or leucotomy from the 1950s. What it involves is putting a small electrode into the brain, into particular parts of the brain, and stimulating that part of the brain using very small electrical impulses in much the same way as a pacemaker might work. It's very effective for Parkinson's disease in particular parts of the brain. It's been trialled now with major depression, and it would be fair to say that there have been a couple of studies that are quite promising. However, what I've written there as the final point is very important. That should be psychosurgery, not psych surgery. You need to go to the psychosurgery board, which is part of the legal process in Victoria, and really it can only be recommended for people with the most severe and intractable forms of depression. And this is sort of what it looks like. So that's somebody who's had 2 electrodes implanted into their brain, and they then have a cord which sits with a pulse generator, which, pretty much like a pacemaker, emits electrical impulses which stimulate that brain. I meant to contrast that with the other slide on that side, which shows an MRI, which shows a different brain region. So the bottom line is, this is very new. We don't know which are the best brain regions to do it. People have tried different brain regions with different degrees of efficacy. So at that point, I'll stop, and I'm sorry I've gone much longer than I expected, but I'm happy for a short time anyway to take questions. And this is from a recent trip that we went to Western Australia, and that's Mitchell Falls, in case anybody doesn't know. That's a Gouldian Beaches. Are there questions that anybody would like to ask? Yes.